Hi everyone, good morning everybody. The fetal heart is one of the most fascinating and challenging organs to evaluate during the anomaly scan. Despite occupying only a small portion of the fetal thorax, congenital heart disease remains one of the most common congenital anomalies encountered in clinical practice. Today, I will discuss the basics of fetal cardiac screening. Based on ISO guidelines for second trimester examination, the goal is not to become a fetal cardiologist overnight, but to learn a systemic approach that helps us identify normality and recognize abnormalities with confidence. Why fetal cardiac screening? Congenital heart disease affects approximately 8 to 10 babies per 1000 live births and contributes significantly to neonatal morbidity and mortality. Early prenatal detection allows better parental counseling, appropriate planning of delivery, timely neonatal intervention, and improved outcomes. Therefore, every anomaly scan should include a complete and structured cardiac screening examination. See this video. Observe this video of transverse four chamber view of heart. Two symmetrical atrium and two symmetrical ventricles are seen with normal rhythm. Is there any abnormality here? What is the red line crossing left ventricle to the right atrium? Is it VSD? No. This is crossing vessel, that is left ventricular outflow tract, crossing midline and goes to the right upper portion of the heart. So, crossing vessel is a must for a normal heart. To clarify this concept, come to the next video. Carefully watch this three-dimensional video of heart. There are three vessels from anterior to posterior: pulmonary trunk, aorta and SVC. Anterior to posterior. See, the pulmonary trunk originates from right ventricle, crossing the midline, goes to the left side. Similarly, the aorta originates from the left ventricle, crossing the midline, goes to the right side. So there must be crossing of LVOT and RVOT of midline, at midline in normal heart. If there is no crossing vessel, this is abnormal. In case of parallel vessel, this is abnormal. This is transposition of great arteries. So in normal heart, there must be crossing vessels. And if you want to get RVOT, you should go to the 3VT plane. See the diagram. Then tilt the probe anti-clockwise 45 degree. If you want to get LVOT, you should go to the 3VT plane. Then tilt the probe clockwise 45 degree. Challenges in fetal cardiac screening. Many sonologists find fetal cardiac screening intimidating. The reasons are obvious. The fetal heart is a rapidly moving dynamic structure. The anatomy changes continuously throughout the cycle. Maternal obesity, scarred abdomen, unfavorable fetal position, excessive fetal movement, rib shadowing and limited scanning time often make images acquisition difficult. However, with a systematic protocol and adequate practice, these challenges can be overcome. Image optimization. Before evaluating the heart, image optimization is absolutely essential. Even the best observer cannot interpret a poor quality image correctly. Grayscale imaging forms the foundation of structural assessment. Color Doppler helps evaluating blood flow patterns. Spectral Doppler and M mode assist in rhythm and functional assessment, while volume imaging can provide advanced anatomical information. Remember, good diagnosis begins with good imaging. Grayscale optimization. When scanning the fetal heart, use the highest possible transducer frequency. Maintain high frame rates. Narrow the sector wide to include only the thorax. Minimize depth and use a single local zone centered on the heart. A magnified image occupying most of the screen allows better visualization of fine cardiac details. Small adjustments in machine settings often make a huge difference in diagnostic accuracy. Color Doppler optimization. Color Doppler should never be used indiscriminately. Appropriate PRF settings, wall filters, persistence and gain are crucial. Too little gain may hide important flow information, while excessive gain can create artifacts. The objective is to display true physiological blood flow and not machine generated noise. This is the checklist of ESOG during cardiac screening: 4th chamber view, RVOT, LVOT, etc. Now come to the ESOG planes. See the plane of stomach and the apical 4th chamber view showing the situs solitus, and there are LVOT, RVOT and 3 vessel tracheal view. Come to the 4th chamber assessment with functional evaluation. The 4th chamber view is the cornerstone of fetal cardiac screening. Before analyzing individual chambers, confirm fetal situs, cardiac position, size, shape and excess. Normally, the heart occupies about 1/3 of the thoracic area and points towards the left side at an angle of approximately 45 degrees. Simultaneously, assess cardiac rate, rhythm and synchronization between atrial and ventricular contractions. This single view detects a significant proportion of major cardiac anomalies. Now, standard 4th chamber view. When obtaining the 4th chamber view, ensure that the heart occupies more than 75% of the screen. The cracks should be clearly visible. Both atrioventricular valves should show normal offset. The interventricular septum, moderator band, pulmonary veins and chamber symmetry should all be carefully evaluated. Never rush through this view. It is the foundation upon which the entire cardiac examination is built. More views of 4th chamber from different resolution machine: apical 4th chamber view and also transverse view. Now come to the rate and rhythm axis. A structurally normal heart may still have functional abnormalities. Therefore, evaluation of heart rate, rhythm and axis is mandatory. Ask yourself, is the rhythm regular? Are atrial and ventricular contractions synchronized? Is the cardiac axis normal? The answer to these simple questions can uncover significant pathology. Now come to the left ventricular outflow tract. After obtaining a satisfactory 4th chamber view, sweep cephalad to visualize the left ventricular outflow tract. The aorta should arise smoothly from the left ventricle with uninterrupted septo-aortic continuity. The vessel should appear as a single vessel without branching. This view confirms the normal connection between the left ventricle and the aorta. These are more images of LVOT, apical view, transverse view, etc. Now four-chamber view. When the aortic root becomes visible arising from the left ventricle, the image is termed the five-chamber view. Although the aortic root is not a true cardiac chamber, its visualization is crucial for confirming normal outflow anatomy. Come to the RVOT outflow tract, right ventricular outflow tract view. Further cranial angulation to demonstrate the right ventricular outflow tract. Here, the pulmonary artery should arise from the right ventricles and curve gracefully behind the ascending aorta. This crossing relationship between the heart, between the great arteries, is one of the most important signs of normal cardiac anatomy. More images of RVOT. See the RVT is branching into left and right pulmonary artery. Come to the three-vessel tracheal view. The three-vessel and tracheal view, commonly known as 3VT view, is among the most powerful screening planes. These vessels should be identified in sequence: the pulmonary artery, the aorta, and the superior vena cava, anterior to posterior. Their relative size should follow the pattern. Pulmonary artery greater than or equal to aorta, which is greater than superior vena cava. The relationship with the trachea must also be assessed carefully. These are more images of 3VT. Now, extended cardiac screening. Once the basic screening examination is complete, more advanced cardiac evaluation can be performed. This includes the aortic arch, ductal arch, bicaval view, and right subclavian artery assessment. This additional view significantly increases the detection rate of complex congenital heart disease. This is aortic arch view. The aortic arch resembles a candy cane. Neck vessels arise from the arch and are clearly visible. Recognition of the characteristic appearance helps differentiate it from the ductal arch and assist in the diagnosis of the abnormalities. See the neck vessels. See the neck vessel originates from the arch. It signifies. So this is aortic arch. In case of ductal arch, there will be no neck vessels. Now come to the these are more images of aortic arch. See neck vessels originated from the arch. Come to the ductal arch. Ductal arch means this is also right ventricular outflow tract originated from right ventricle and bypassing ductus arteriosus continues to the aorta. This whole arch is called ductal arch. It's candy cane, it is hockey stick appearance. No neck vessels originates from it. Understanding this distinction is fundamental when evaluating the great vessels. See and identify and evaluate the images. These are spine anterior position. In these two arches, there are no neck vessels originating. So this is ductal arch. This is also ductal arch because no neck vessel is originating. The left one is ductal arch and the right one is aortic arch because there is neck vessel is originating. This is bicaval view. Just some parasagittal section. We can see IVC and SBC draining into the right atrium. full screen view and heart occupying 75% of the screen, spine posterior, showing right atrium, IVC and SVB must be there. The normal right subclavian arteries. After going to the three vessel tracheal view, tilt the probe and tract the neck vessels, that is brachycephalic artery, which is dividing into subclavian artery and right common carotid artery. If the subclavian artery, normal right subclavian artery, curving in front of the trachea, this is normal right subclavian artery. Normally, right subclavian artery curving in front of the trachea and extending to the right atria. In case if the right subclavian artery curving behind to the trachea, it is called ARSA, that is aberrant right subclavian artery. Aberrant right subclavian artery is a soft marker of Down syndrome. More images of NRSA or normal right subclavian artery. This is a video of right subclavian artery, the blue one, curving in front of trachea and extending to the right arm. Now come to the sample video of fetal cardiac screening. Then fourth chamber view, then LVOT, and coming to the cephalad position. This is right ventricular RVOT, branching, abdominal aorta, ASVC. This is three vessel tracheal view. RVOT, branching vessels. LVOT, and now fourth chamber view. Descending aorta. Come to the next video. Stomach should be seen. Stomach and the apex of the heart is in same side. This is situs solitus. LVOT. I am forwarding this video. See the arch, ductal arch. This is ductal arch. No vessel, no neck vessel seen. So this is ductal arch. Aortic arch. Neck vessels is originating. This is aortic arch. Now come to some common cardiac anomalies. As not all congenital heart disease alter the fourth chamber view. Conditions such as tetralogy of Fallot's, transposition of great arteries, double outlet right ventricles and aortic arch abnormalities may have a seemingly normal 4-chamber appearance. This is precisely why outflow tract evaluation and 3VT assessments are indispensable components of modern fetal cardiac screening. Associated with abnormal 4-chamber views, there is mitral or aortic atresia, tricuspid atresia, pulmonary atresia, Epstein anomalies, tricuspid valve dysplasia, atrioventricular septal disease, large VSD, single ventricle, severe aortic stenosis, pulmonary stenosis, coarctation of aorta, total anomalous pulmonary venous connection, cardiomyopathies, heart tumors. Approach to our doubtful finding. When faced with a suspicious finding, do not jump to conclusions. Rescan the heart in different fetal positions. Use grace color and color Doppler. Evaluate systematically. Describe what you see rather than what you think. Seek expert opinion whenever necessary. A disciplined approach prevents both overdiagnosis and misdiagnosis. Even when a fetal echocardiographic examination is performed according to recommended standards, certain lesions may remain undetectable prenatally. Small ventricular septal defects, coronary anomalies, some aortic arch abnormalities, and anomalous pulmonary venous drainage may not always be identified before birth. Therefore, a clear disclaimer should always accompany the report. Beyond diagnosis lies a greater responsibility. Every detected cardiac abnormality should be interpreted in the context of prognosis, quality of the life, available treatment options, and family expectations. Our role extends beyond the image acquisition. We guide families through critical decisions with knowledge, empathy, and professionalism. Fetal cardiac screening is not difficult when performed systematically. Never issue an anomaly scan report without evaluating the fetal heart comprehensively. Remember, during routine screening, your responsibility is not necessarily to establish the final diagnosis but to recognize and report abnormalities that warrant further evaluation. The fetal heart may be small, but its impact on the future life of a child is enormous. Every careful examination has the potential to change a family's future. Thank you very much for your kind attention. I sincerely hope this session encourages all of us to approach fetal cardiac screening with greater confidence, precision, and enthusiasm. Thank you very much.